way, I'm wishing you, all of you, a very happy Doctor's Day. Yeah. So today's, I'm sure we are starting session. So to commence today's session, it is my pleasure to invite our Dr. Ashish Gowde sir. Welcome our esteemed chairpersons and introduce to the moderator. Thank you so much. Over to you, sir.
Thank you, Vishali. Good evening, everyone, and a very, very warm welcome. I know it's a very rainy day. It's a typical Mumbai rains, which all of us are familiar with these July rains, and conducting a meeting in Parel is not so easy. But fortunately, I'm happy that most of you could come here. Some are still on the way, but of course, in the interest of the time, we will go ahead because there is a webcast also happening of this session at other centers, so we need to stick to the time. We have been associated with the vitreoretinal surgeon for more than a decade now with the launch of aflibercept or Eylea, which we did in 2016. And we are very happy that this has really made a great progress, not only in terms of the business, but in terms of all those patient lives where it has really made that kind of a clinical significance for them. And to discuss that, we really have this important session where we are very happy to have Dr. Stewart here. But along with that, we also are very happy to have our chairperson, sir, Dr. Prashant Babankulde, sir. I mean, sir, we know him very well, but just to give a few accolades, sir is a director for Sarakshit Netralaya Nagpur, and the key thing, I wouldn't take much time, sir. Only one key point that I would like to mention, that sir has served as a chairman for the academic and research committees of the AIOS. Sir has been awarded with many awards. Just to mention the recent one, ASRS Honor Award. We are also very happy to have Chairperson Dr. Vatsal Parikh, sir. Sir has also been working as a director for Drushti Eye and Retina Center. Again, sir requires no introduction. He has been the vitreoretinal practice for more than 4 decades now, and he has that state-of-art retinal center where he has been dealing with these patients since long time. Coming Saman sir, he has been associated as a director for Acura Sight Eye Clinic. Again, key highlights for Dr. Saman sir, he also has been there in the practice for more than 25 years. But the important part, sir, has served as a past president of Bombay Ophthalmology Society or Association, and has been a scientific chairman of Maharashtra Ophthalmic Society. He has also received numerous awards. With this very brief introduction, I would like to hand it over to Dr. Saman sir for the further proceedings.
Thank you, Dr. Ashish. As retinal surgeons, we are always wondering whether it's dry or it's wet. Nice to see everyone dry and cozy. I would like to introduce the expert panelists for today's deliberation. We have with us Dr. Paritosh Kamdar, we have Dr. Tulur Sekar, we have Dr. Firoz Patel. He's still on the way. Okay. I invite Dr. Anand Subramaniam. Dr. Sonal is still on the way. Okay. Dr. Jaideep Valenchkar is with us. And Dr. Jay, he's still on the way. Okay. So we have some panelists coming in. And I have been given the pleasant task of introducing none other than Professor Michael Stewart. Professor Stewart is professor and chairman of the world-renowned Mayo Clinic, Florida. Eye Foundation Professor of Ophthalmology and Research. He completed his medical education at the Harvard University and then did his fellowship at California Davis and the Retina Research Foundation. His primary research areas center on chorioretinal vascular disorders like AMD, diabetic retinopathy, and also complex vitreoretinal surgeries. What is noteworthy is his specialty in mathematical modeling of ocular pharmacology and analyzing drug half-lives and dosing frequency for patients globally. I think this is the crux of what we are battling with when we deal with medical retinal disorders. So without further delay, I would like to invite Professor Stewart for his talk today evening. Professor Stewart.
Thank you. Very good. But thank you for coming here on such a wet day. I was told in Delhi that more from. Indeed, I wasn't disappointed when I got on the ground today. Pleasure to be here. Thank you very much to the Board team for inviting me. Always a pleasure to be here. As I've flown through Mumbai multiple times, this is actually my first time out of the airport into the city. So even on a day like this, it's a pleasure to be in the city and to see parts of the city. Are you ready with that? Okay. So thank you. All right. 20 slides with some. And I'm going to say that probably people will agree with. I'm going to say things that people may not agree with. And that's a good thing because I think those things will lead to discussion as we give point and counter 30 minutes afterwards. Or that you do differently than what I do, because that's how we learn from each other. So we're talking about VEGF therapy. Here are my disclosures. Of course, I am a consultant for both Bayer Pharmaceuticals and Regeneron. Regeneron, of course, is the company that developed and makes both aflibercept 2 milligrams and the newly approved aflibercept 8 milligrams. So talking about probably as we go into individualized therapy, which is, of course, where we've been going now for 15 years, nothing is more important to us than the analysis of fluid with regard to being able to figure out, do patients need to be extended? Do they need to be treated more often? And so we take a dive into fluid to understand what fluid's important and what necessarily is not important. I think we've come across over the last few years the same. And so we see a single measurement of how thick the macula is, but for us to really understand how important it is, we need to know what contributes to it. And of course, we go down to the 3 different fluid compartments. We have a pretty good understanding that intraretinal fluid in red, and I'm really specifically talking about age-related macular degeneration, is really adverse to visual outcomes, both levels of follow-up. And as much as we can, we should probably try to get rid of intraretinal fluid as much as we can. We can't always do it, but that should be our goal. Subretinal fluid is a little bit differently. So now we have fluid between the photoreceptors and the retinal pigment epithelium. There's a lot of data that suggests the subretinal fluid is not necessarily bad. A lot of fluid, of course, does interfere with vision. A small amount of fluid may truly be helpful with respect to baseline visual acuity improvements, and perhaps long-term health of the photoreceptors in the pigment epithelium. That's a controversial statement that not everybody will agree with, and I certainly welcome questions at the end. But to have to get rid of someone or AMD cases. And finally, we have the subpigment epithelial space. So pigment epithelial. Okay. So pigment epithelial detachments are sort of neutral, unless they're accompanied by either subretinal or intraretinal fluid, in which case the pigment epithelial detachments are detrimental to vision. But in and of themselves, if I can get rid of intraretinal fluid and I can get rid of, or at least improve subretinal fluid, I'm generally not worried about a pigment epithelial detachments in both cases. So what data do we have to suggest that subretinal fluid may actually be helpful or tolerated? Well, this fluid study did was they looked at eyes with subretinal fluid that was at least less than 200 microns thick. And they randomized patients to either very aggressive monthly therapy to try to get rid of the fluid or tolerate the fluid. And then they looked at visual acuity outcomes over time. And what they found was it didn't really matter if the fluid were treated aggressively versus if it were tolerated. And the tolerated patients, of course, received fewer injections. Whether you corrected visual acuity at month 12 and 24, or 15-letter gainers, it was exactly the same, whether they were treated aggressively or not, in the presence of persistent subretinal fluid. Alter and Aries were two phase 4 aflibercept 2 milligram trials. And in the Aries on your right, they actually tolerated less than 50 microns of subretinal fluid, less than the fluid trial, but it was tolerated, in fact, tolerated to extended as long as the fluid were less than 50 microns. And those patients actually did very well. In Altair, fluid were tolerated only to the point where patients could be maintained, but if there's subretinal fluid present, they were not allowed to be extended. So it treated just a little bit differently. But nevertheless, it wasn't a reason to shorten the interval. Subretinal fluid could be tolerated in Altair. Probably the best data on fluid comes out of the Harbor trial. The Harbor was a very good phase 3B trial by Genentech, and it looked at ranibizumab 0.5 milligrams, ranibizumab 2 milligrams, treated monthly or on a PRN basis. In a post hoc analysis, they looked at the presence of fluid and correlated it with vision. And what they found was that for intraretinal fluid, it was bad for the vision at baseline. It was bad for the vision at follow-up. Those patients did not do very well. For subretinal fluid, it was exactly the opposite. Patients with subretinal fluid had better vision at baseline, better outcomes. We've seen trials also fluid persisting versus subretinal fluid did not seem to make much difference. And then as we go and look at some of the other big trials and post-hoc analyses, the view, of course, looked at this over time with intraretinal and subretinal fluid. Subretinal always did better than the intraretinal fluid patients. CAT, for a 5-year analysis, showed exactly the same thing. Patients with intraretinal fluid did well, and well means better than average for the study. Hawk and Harrier, probably there's no drug that brings out the concept of retinal drying than brolucizumab. But we know that even it did in Hawk and Harrier, and I'll show a little bit more data later, the visual acuity changes really didn't didn't differ from aflibercept 2 milligrams. Why did it not differ when the drying? We on visual acuity in those trials that actually correlated and reported them at all times. And our analysis showed exactly that. When you look at the literature, every trial through 1 year that had intraretinal fluid persist showed a negative outcome on visual acuity. With respect to subretinal fluid, the results were mixed. Either the subretinal fluid had no effect on vision or it was better for vision. And when we looked then at beyond 1 year, 2 years or more, we found exactly the same thing. Fewer trials, but every the studies that had subretinal fluid was either neutral or protective, meaning it had better visual acuity. So we get back to Hawk and Harrier and brolucizumab, and as I said earlier, brolucizumab central subfield thickness, you can see that at nearly every time point, maculars are drier with brolucizumab than they are with aflibercept. But yet visual acuities were exactly the same in the aflibercept versus the brolucizumab group. Why is that? Well, when you look at the top and you look at the left in green, you see that more aflibercept eyes had subretinal fluid. You want to get rid of. Brolucizumab did exactly the same as aflibercept, hence the visual acuity results were the same. But yet, for the fluid that is less important, that is the subretinal fluid, there were actually drier patients with brolucizumab than there were with aflibercept, but it doesn't really matter because subretinal fluid is not adverse to visual outcomes in the long run. Well, what about Vabysmo? Vabysmo was started as a superiority drug, and Genentech went through a phase 2 trial called the Avenue trial, and they looked to get superior visual acuity results with brolucizumab versus ranibizumab monthly, but it didn't work. So they quickly pivoted, and they changed from being a superior drug to a durability drug. And then they came up with Tenaya and Lucerne for their phase 3 trials. And when you look at the visual acuity results at the end of 1 year, that the Vabysmo or the faricimab groups had the same visual acuity results as aflibercept 2 milligrams. And there's a lot to be made out of statements of drying with Vabysmo. It dries quickly, it dries better. But it's interesting when you look at the results straight out of the trial that I've highlighted in the bottom. When you look at the first 16 weeks or so, in both Tenaya and Lucerne, the eyes treated with Vabysmo seem to be drier. But once you hit week 20, that's no longer the case. From 20 through the end of the trial, the drying effects are exact. And as a result, the visual acuity results are also exactly the same. They get a sawtooth pattern with aflibercept 2 milligrams. We know that. You get a sawtooth pattern also with Vabysmo. And you can see how they cross each other at various places. And so from week 20 on, the drying effects of Vabysmo are essentially the same as the drying effects with 2 milligrams from Tenaya and Lucerne. And so the optimal management of macular degeneration, thickness and fluid presence, but a matter of where is the fluid. Do we tolerate it? Do we not tolerate it? Intraretinal fluid, we try our best to get rid of it. But sometimes after 6 or 7 monthly injections and you don't get rid of all of it, you kind of give up, which is probably appropriate. And I would even start to extend some of those patients, even in the presence of intraretinal fluid, if I can't get rid of it. Because at some point you're just chasing something you can't fix. But subretinal fluid, though it's nice to get rid of it from the standpoint of thinking we now have the disease under control and we can extend comfortably, it's not necessary to do that. And we have lots of data to show that you can start extending once you've improved and stabilized subretinal fluid. And so it's really a differential approach, and that's where the individualized therapy comes in with treat and extend, just as it does with PRN studies. We just know that treat and extend gives us better visual acuity results than treat and extend and then PRN, because we allow the retinal disease to recur fewer times. The more you allow the blood vessels to come back, the greater the risk of permanent vision loss. So I have a couple of cases to show, and I'll mix these in. This was a patient as a former U.S. Marine, macular degeneration. He came in with 20/40 vision, and you can see he's got intraretinal, sub-RPE fluid. So what is my goal? Well, my goal is certainly to get rid of the intraretinal fluid. The subretinal fluid I'd like to improve and at least stabilize, if not get rid of it. And the pigment epithelial detachment I'm not too worried about. Type 1 choroidal neovascular membrane. He actually was started on bevacizumab. Treated him 3 times monthly, and you can see him down at the bottom now after 3 injections. The vision has gotten worse. The pigment epithelial detachment has gotten worse. And so we have no really firm criteria for when one looks to switch patients, but 3 months is a commonly used number. And so, especially in the presence of worsening vision and increasing pigment epithelial detachment, I switched him to aflibercept 2 milligrams. And interestingly, he flattened completely, and his RPE detachment flattened as well. And he did actually very well with no reactivation. You can see he's 20/25 now at the bottom. Rather, visually, he's actually doing very well. So, and I said, here's where I made my mistake. After 3 years, I decided to go ahead and stop injections and observe. I'll often do that if I get patients to 12 or 16 weeks. I did in him. I went away. The patient comes back. He's now complaining of decreased vision. In this sign, you can see he's got some intraretinal fluid and thickening, and his vision has dropped to 20/30. He gave him brolucizumab, and unfortunately, patient hemorrhage soon thereafter. Intraretinal fluid, and he's got a disciform scar a year later. So unfortunate result. Looking back on it, I wish I had never stopped therapy, but nevertheless, that's what he ended up with. So now he comes in with decreased vision in his other eye, and he's about 20/50. Now you can see a pigment epithelial detachment, subretinal fluid, and now I'm treating him with aflibercept 2 milligrams every 4 to 6 weeks. And after 9 months, he's 20/40. He's fairly stable, and he's somebody I will treat for life. And I've kind of gotten him at 6 to 8 weeks, and that's where I've treated him now. And I'll never stop in this only eye, and I won't switch drugs because I know he had done previously very well. This then begs the question of when do we switch and what are our criteria for switching? And if anybody has abs, I'd love to hear them, but none of us do. So I'll give you some of the data that's out there. 2006, but we could as to my age. And so that's switching was not an option. Figure out was how often to give it. And now, as we go through our list, and of course we have biosimilars to add on to that, we've got a lot more options, and so our jobs become considerably more complicated because we have a lot more decisions to make. And we have to decide which drug are we going to use. Are we going to switch it? What interval are we going to use? One thing that we often think of is the most often you give a drug is every 4 weeks. That's actually not true. I've given drugs every 2 weeks if needed. And sometimes it works well at 2 weeks. I think that 4 weeks is the absolute maximum frequency you can give it because some patients will respond to 2 weeks. 4 weeks. We talk about primary response after the first injection, secondary response after 3 loading doses, and then subsequent to that. Here's grid that looks to define good, partial, poor, or non-response to anti-VEGF therapy in macular degeneration. And it's doing it based on morphology and based on function. The easy way to think of it is functional improvement, anything better than 5 letters is generally good. Functional morphology improvement, if you've decreased down to less than 75% of your fluid, more than 75% of your fluid, you've gotten a good response. Whereas a poor response is loss of vision and worsening or stable visual acuity. And so what do you do with that? Well, you can take another group and do that. But generally speaking, those eyes that do well, we continue therapy. Those that don't, after some interval, be it 3 months or 6 months, is sort of based upon our own particular approach to these patients. Does switching actually work? Well, switching is probably overrated. So here was a trial out of Japan, and it was patients who were switched from baseline from aflibercept to faricimab. And after they switched, 60% of the patients stopped at faricimab. They weren't responding well. 73% actually switched back to faricimab. And there was very little change in vision or in central subfield thickness after the switch. So here's another study out of Japan, again, after 3 faricimab injections from patients being switched. The majority of these patients, more than 70%, still were treated frequently at less than 8-week intervals. So the switching there did not help very much. This is another one out of Japan by Hara et al. And they actually looked at visual acuity outcomes with aflibercept versus faricimab, and they found the aflibercept 2 milligram patients did better than the faricimab patients did. And then finally, out of Great Britain, Bailey et al. Looked at DME patients and switching them, and they found that patients who were switched mostly from aflibercept 2 milligrams to faricimab had very change in visual acuity, less than 11 of those patients that were switched to faricimab, very few of them actually got extended intervals. So switching I look at as a poker game. And for those of you who like to play poker, you can think of very high-risk bets or very low-risk bets. Switching is a high-risk proposition. Sometimes you can hit a home run, American jargon. What is it in cricket? You get a wicket? Okay, we get a wicket. And sometimes you don't. The thing about switching that I would encourage people to think about is try to be consistent and be always prepared to switch back, because sometimes you're not going to get the results you're looking for when switching. And this very recent article out of Moorfields came out that looked at early outcomes with faricimab versus aflibercept in diabetic macular edema, and they found that results were essentially the same in patients with DME when treated with the 2 different drugs. So here's a case of a switching case. This case very surprised me, and I think it'll surprise people here. 65-year-old lady with a 20-year history of type 2 diabetes. You can see she's got edema greater in the left eye compared to the right eye. And so I treated her, and she's gotten a reasonably good response. She's not completely dry, but she's 20/30 and 20/50 and done with aflibercept 2 milligrams every 4 weeks. So in the United States, and I don't know if that here exists in India, and drug companies love to give commercials on the new drugs. And they have brolucizumab, they have faricimab, they have aflibercept 8 milligrams. So at this time, aflibercept and Vabysmo were ready. She said, I want to switch drugs. I said, okay, if you want the data looks good, let's switch each eye to a different drug. And so we switched brolucizumab in the right eye and faricimab in the left eye, and which really surprised me. So we switched her to aflibercept, and she got back to where she had been before. Again, perfect result, but a better result than she had after switching. So there's tremendous variability between patients in terms of their response to drugs. And the best way to think of that is when you look at visual acuity results and the central subfield thickness results from our trials, you always see the mean, which is what's on the graph, and you see the standard deviation. Standard deviation means variability. Many times the standard deviation bars overlap, hence meaning one drug is going to do better than the other drug on any. Be prepared to switch back, and switching to a drug where you think has a greater drying effect doesn't always work. You can try, but doesn't always work. There's a patient who, another diabetic patient treated by me for several years, had done some laser in the past, had done bevacizumab, was switched to aflibercept 2 milligrams, but over the course of years, aflibercept 2 milligrams every 4 to 6 weeks. So faricimab became available. So let's switch you to faricimab. And so we did 1, 2, 3 faricimab injections, and her visual acuity dropped to 20/70 after 3 monthly injections of faricimab. So again, not an expected result, but once again, keep in mind that when you get an early poor result, or do something different. We may talk about the rest of this case later, but we'll stop at this case right where we are. We're looking for. So thoughts on faricimab. I was sitting next to Peter Kaiser from Cleveland Clinic at a meeting. He was sitting next to me and we talked about faricimab, and he says, they looked at the Cleveland Clinic data and this is what they found. A patient switching from aflibercept 2 milligrams to faricimab got better. A third stayed the same, and a third got worse. Of those third that got worse, when they were switched back to faricimab, they got better again, back to where they were. So it sort of mimics what I've seen in those few cases of those patients that get the ones we're expecting, but other ones that get worse, they tend to get better again when put back on the first drug. So there certainly is some sort of individualized response to medication. The Truckee study was a phase 4 trial with faricimab, and in it, they looked at some treatment-naive patients and mostly switched patients. They found that the switched patients had only very modest improvements in visual acuity. This study I dislike. There are lots of studies like this. I dislike this one because for 2 reasons. One is it's a non-controlled post-approval study that has switching, and switching almost. What do you switch? Why do you switch? What are the intervals? And there are only 2 really good switching studies, I think, in all of ophthalmology that we've been seeing. One is DRCR-NET AC. AC was done by the DRCR-NET, and they switched patients from bevacizumab to aflibercept in very rigid criteria. And the other was SCORE-2. SCORE-2 was the vein occlusion trial, where patients after 6 months were switched from either bevacizumab to aflibercept or aflibercept to Ozurdex. So those are the 2 really good switching studies. Everything else is with a grain of salt. This was a really interesting study. So I want to look at the title. Effects of switching and VEGF intravascular endothelial growth factors for age-related macular degeneration and diabetic macular edema. This is done by DRCR-NET I trial as well as CAT. So what's wrong with the title? There was never any switching in either of those trials. They never switched patients. But what they did, doctors, and this was Rick Ferris and Dan Martin, they looked at their data and they said, well, who got switched if there were switching? Probably the patient who had poor response at 3 months or 6 months. They're the ones that would have been switched. They were never switched in these trials, but what happened when you continued therapy with the same drugs? And you can see in this macular diabetes in the bottom, patients generally got better, slow responders. For 3 months or 6 months, they didn't get much improvement. And so they continued therapy and the patients got better. Now, if they had been switched, gotten better, and they were switching, the reality is they were just slow responders. So it's a really interesting. Or sometimes you see the effects of this simply by time and not by changing drugs. So lots of different pathways and drugs that we have to deal with. And is the Ang2. So interestingly, Ang2 was actually discovered in general. And they created a drug called Nivolumab, which is an we're not going to do that. And the reason is we need a superiority trial because it's 2 drugs, and we're not going to get a superiority. But Genentech also went and they created one drug. Superiority, they could get a good effect with Vismo because they didn't need superiority since they had only one drug. And of course, Tenaya and Lucerne or Yosemite and Rhine, the results compared to aflibercept 2 milligrams were essentially the same. Questions though become up is, what is this drug? Well, it's brand is for VEGF, and it's the H2 binding from what's called an LC10 antibody on the other. Discussion with a genetic scientist shortly after it came out in a break in a meeting. He says, we have no idea if H2 binding actually does anything. This is one of the guys who interesting stuff. Ang2 certainly has a role in terms of angiogenesis. Regeneron people, and Georgian Coppola is one of the guys who discovered it, quickly decided we're not going to go there. It seemed to be upregulated by VEGF. When VEGF levels rise, it pushes Ang2 levels up with it. And so the inverse of that is if you VEGF by giving Ang2 levels fall. And so that's been shown both in preclinical trials as well as in clinical trials. This is from the Avenue trial. Remember I showed you the one they tried to get superiority and couldn't. They measured Ang2 concentrations in all of the different components in the Ang2 trial. They measured Ang2 at baseline and they measured it 28 days later after the patients had already been treated. And in patients at baseline. In the other colors, the Ang2 concentration 28 days later, and the Ang2 concentrations fell to near 0. Well, before it fell the most. So it fell most in an eye that didn't have faricimab, just in ranibizumab. And so what's interesting is you lower the Ang2, the VEGF concentrations, you lower the Ang2. So we're not sure what Ang2 does. But and has characteristics that are in of Ang2 binding. And has a high size, has a long individual half concentration. All those are positive. Ang2 contributes to that or not. Biologics that have experience has with respect to ranibizumab, understand that biosimilar out as well. Still, we have 5 aflibercept biosimilars that have been approved. We have 1 that's available. Many of the others are caught up in litigation, patent litigation, because patents are all a big deal in terms of when drugs can come out. The interesting thing about the biologics is if we have a small standard drug, 300 or 400 of the original drug. The biologics, it's very different because we don't know the three-dimensional fluid, we don't know the constellation, and that's why we call them biosimilars are similar looking. And so we think they have similar efficacy and safety, and that's what we want to try to establish. But it's hard to figure out exactly. One of the differences between the biosimilars and the the glycosylation, the glucose moieties that are actually bound onto the molecule to improve its half-life stability and safety. There's no roadmap that gives the biosimilar companies the ability to replicate what the original company did. So therefore, it raises question about efficacy, durability, and safety. So therefore, pharmacovigilance bevacizumab, what we found out post-approval was critical in terms of affecting how often or infrequent or infrequent we're going to use the drug. Same applies to these drugs. We need to learn about safety after drugs better going forward because there's obviously lots of interest in terms of trying to do either better efficacy, better durability, make sure safety is unchanged. That's the critical feature, right? Everything else is relative. Safety has to be the case. Other than is we want the drug to stay above the concentration needed to suppress VEGF as long as possible. One of the ways to do that is to make the drug a better binder, stronger binding drug, because then it will work at a lower concentration. The aflibercept is far and away the strongest either clinical or experimental binder we've already had, so we're not going to get better than that. Those ways are to increase the molar dose, and that's been the strategy recently, hasn't it? Bevacizumab, why is it? There are lots of reasons. One of which is a very high molar dose. Faricimab also has a higher molar dose than aflibercept, and that why aflibercept works well also. And of course, now Regeneron and Burger have gone down that pathway with 8 milligrams by quadrupling the dose. And once again, looking at not improving efficacy, but certainly to improve durability. And the way to think of that is in this cartoon is you simply, over time, in a higher molar dose, you have more molecules left in gravity. It's increase the durability before you get a reactivation of disease. One of the things we find is that the durability and efficacy are related to each other. And the reason they're related is the antibody, the concentration of the drug and its binding over time is higher at the beginning, it's higher at 3 or 4 months later, and the higher it is at the beginning, the VEGF concentration is that's unbound. And so for those patients who require very frequent intervals, drug can actually shift them over and decrease that number of patients. We call this shifting the curve. And then for maybe they're doing 3, 4 months, you can actually extend them out to 4, 5, and even 6 months, which is what the new 8 milligram data shows us. And so Regeneron and Burr have gone down blood that would be access to fairly soon. You're going to use it yourself and see what it does, both in terms of durability as well as in terms of switching for patients who are difficult to treat and those patients to get a really quick drying effect at the beginning because of that decreased free VEGF concentration that exists when you treat with more of a drug. And so a couple of last slides. One is global patterns. This is from the ASRS. This is the 2025 PAT survey. They ask questions of what's your first line therapy for macular degeneration with no payer restrictions. Internationally, it certainly favors, and even domestically, it favors the aflibercept 2 milligrams. And then and I think many people are still very strong proponents of BRCA protocol T, which I am, and the aflibercept is always my go-to drug for those patients of 20/50 or worse because the data was so compelling from protocol P. So aflibercept 2 milligram has really been a global leader. I think I heard you received it here in 2016. We received it in 2012, right after it was approved. Excellent efficacy, safety, and an unparalleled durability and unparalleled safety profile. And so those are all the attributes of the drug. Not only 2 milligrams, but I think what you'll see, and as the data is beginning to show, the same thing applies to 8 milligrams as well. So thank you. That's to the panel. No questions? Yes. Milligrams?
Single patient?
Oh, actually, a single patient.
Patient.
A single. Yeah, patients have
No.
injections.
One patient during his entire lifetime, how many injections, maximum injections? So it's like the question why I am asking is because the patients who are throughout their life
Yes.
and we keep on injecting.
Yep.
That drug do happen.
Yes.
In clinical trials, we never actually address to chronic kind of issues like renal changes, or it is we only address to neural issues. So,
At least some of what I think you're getting at is treating these patients over time. And you know, I've had aflibercept patients I've treated since 2012, and I've treated. That's what they've needed. I've had bevacizumab patients, a couple of them I've treated since 2026. So I have a shorthands here. And because you mentioned renal disease, and I think that's an important question. So how many patients here that is to occur from intravitreal anti-VEGF injection of any drug? How many people have seen that? One. Ranibizumab, that we think was the case because it was a attempt. So I think that's one of your questions, right?
patient developed acute renal injury who was on antibiotics.
So, on ranibizumab. So it exists, but it's very rare. The one that we had on ranibizumab changes, the drug was stopped, the renal got better, and then it was somebody else that tried it again, and the renal got worse and then came back again. I don't know if your patient recovered or not. Did your patient recover?
She did.
She did. So, it was two of the two recovered. That's the good news. The next thing was that I asked patient at people here to show hands, it was only 2 of us. And so I think the incidence of renal disease, and we know a potential complication that anti-VEGF, because if you give it intravenously, then it's looked at. But if you give it in the eye, exposure is so low, not zero, but systemically that it's very small.
We've seen asymptomatic pyuria occurring in a few patients.
Okay. I would take it seriously, because I think that's an important. The issue is it comes from all the first generation drugs, and most likely will come from the second generation drugs too. So those speak as physicians, right? We have to. The drugs exist in the serum because they exist for a while because most of them have fairly long half-lives because of the FC fragments. And as a result, they lower serum VEGF concentrations, but that rarely extends to a systemic complication. At least that's what we believe. I mean, we're still struggling to this day. Here we are 20. We're struggling to this day to figure out, do intravitreal injections increase the risk of myocardial infarctions or stroke? And there's no good data to say that it actually does. But a concern, absolutely. That's what
there is quite a literature available with the physicians, especially the renal physicians who are talking about stopping any form of anti-VEGF therapies. They feel that we are inducing more toxic. What's the status in US and how do you tackle the patients, renal physicians with
So me, and maybe not as well aware as the Indian nephrologist, but they do contact me, and some patients that I'll talk to and say, I noticed what your creatinine is doing. And I keep an eye on that over time. But I've gotten feedback other than that one patient of I'm worried. And I've never had a primary care physician tell me to stop. I think that if you get that, then you've got to say, well, let's take a step back. Now, what are the patient's comorbidities? Is this patient hypertensive? Do they have renal disease? Do they have diabetes? Do they have some other primary renal disease that's causing this? And then you look at the incidence out of the literature of not just case reports, but the incidence that comes out of trials. Trials, and you have CAT, VIEW, TONAI, and Lucerne, they're all different renal function panels in the trials. And when you look at the systemic complications of those trials, reasons that randomized trial. So I think that's where it becomes difficult for us. But what is our alternative in a patient who has macular degeneration? Patient, you could be talked into giving steroids. But in a diabetic, in a macular degeneration patient, we have no choice. And now, if I take a deep breath and say, maybe I'll watch you. If I develop renal failure, then we have to be detectives and physicians. But just as a don't go with that, but we have a conversation with the physician.
Because few of the renal physicians have started pointing out and they are making a note in the notes that. And
supposing a poster patient for ILIA, he'll tell you back, no, you put him on ranibizumab. So I think they have a nephrology further which has published a lot of data which we are not getting, They
To say that ranibizumab is safer on the kidneys than aflibercept is. That's one. If there is data, I'd love to see it, but I have not seen it. Two, we know ranibizumab's serum half-life is very short. The serum VEGF concentrations is much lower than aflibercept is. Aflibercept lowers systemic VEGF, but that doesn't correlate with kidney disease or stroke. So if they say that in the conversation, I might say, okay, I'll do that.
yeah. Say yes.
Yeah. Now, and we know that in most patients, they're going to respond well to ranibizumab. Now, if they respond quickly, then it's a different conversation, but most will respond well.
I would like to just rephrase the question which Dr. had asked. What for stopping therapy? So is she was asking about decide to stop therapy.
Yeah.
And biomarkers you would look at and the clinical profile of the patient when you decide to stop. And secondly, when now switching, you had shown that this is something which is not like faricimab, ranibizumab, it's a controversial thing. Probably sometimes go back to aflibercept. So aflibercept versus aflibercept 8 milligram experience in switching between these two.
So the first question is a really good question on stopping, and people have debated this. So I think there are a couple of criteria that come up. At least most of these are criteria that came up before the second generation drugs became 16, 20, 24-week intervals. Do we need to treat a patient at a 24-week interval? And the answer is on average, probably not. For most of those patients, if you can get them out towards 20 or 24 weeks, you can probably watch them and they'll injections. So, what are the magic numbers? I used to say 12 weeks. Now I'm going to 16 weeks just because the second generation agents are I have good data through 16 weeks. So if I'm a patient to 16 weeks, they're completely dry, and they're dry through probably two different 16-week intervals, then I'll offer to stop it. And then I'll see them back at 8 weeks, and then I'll see them at 12 weeks, then I'll see them at 16 weeks, then I'll follow them at 16 weeks. What happens in macular degeneration patients over the course of 5 years, 6 years, 7 years? We know that what happens, the vision drops, right? It does. That's what I found. I mean, obviously macular atrophy is a big thing, but in terms of drugs, the patients who are treated the most have the lowest chance of decreasing vision over time. They're not controlled studies, but they're just different studies that are compared. And so treating patients more likely preserves vision than treating them less. And so I'd like to have a fairly low threshold for reinitiating therapy if I've stopped it. And I also don't want to see them any less frequently than every 16 weeks or so. So that's generally my thought about stopping therapy. For DME, it's quicker to stop DME. If I get patients out to 10 and 12 weeks and they're dry, I'll go ahead and offer to stop them and watch them. And why? Because it's a much more forgiving disease. Because DME, if the fluid recovers, the vision drops, you're right back to where they used to be. In AMD, that may not be the case because you have progressive fibrosis, RPE damage, photoreceptor loss. And so in AMD, it's not forgiving. And so for that reason, I'm much more reluctant. A range patient with AMD generally never stop them. Might get them to 16 weeks, but I'll never stop because I just worry that if I do, they're going to go downhill and I'm going to not be able to recover. DME, then I will stop and I'll. The other question was
Switching between 2 milligram and 8.
but you milligram. Patients on 2 milligrams. And they're coming in and talking to their friends, and so keep them on. But for those patients who have I get a feeling they'd rather not be here every 16 extend it further. So the good responders, and we want to make them longer, then yes. And generally my feeling is it's about 50%. For those patients who respond well, and I switch drugs, I get about a 50% extension of the duration. If those patients are poor responders, every 4 weeks they've got fluid. If everything else often gets them dry, but I'm never going to get them beyond 6 weeks. Not with most patients. I can get them dry, but I'm not beyond 6 weeks. And then there's going to be a subset of patients who are not going to respond much better. But that's.
So I have a same an extension to the same question. With 2 milligrams, we are usually aiming at Q12 or Q16. But we decide, okay, now let's try and take a chance, stop and see. So with 2 milligrams, if it's Q12 and Q16, then what is the magic number with 8 milligrams?
It's still the same number. It's the same number. It's just you get it quicker and you get more patients.
Stop or would you?
So to try to 24 weeks. Stop the patients, so we don't really know.
Because when you let's say if you're going to extend to Q20 or Q24, then you're not calling the patient in between. You're taking a chance.
Right. So the point is, once you start going out beyond 12 and 16 weeks, you go to 20 or 24. Now you've got 24 weeks and you haven't seen the patient. So that's the treat and extend. Or proven that they do okay at 20. So you have a degree of safety built in. The ones that don't like is 3-month injections and then Q16. I think that's too big a leap of faith because now you've got nothing in between. But if you and 16 to tell you they're safe at those intervals, the downside is you're not watching the other eye. So if you has no neurovascular AMD, and of course I do an OCT in both eyes every visit. I imagine most people do, because it's a good way of following the other eye. Now I'm watching the other eye for 24 weeks, and I feel a little less comfortable too. But again, with treat and extend, I think you can do that. with a rapid Q4 weeks, Q16, which the trials did, I'm not as happy doing that. I like to do them in between.
Right. Now, conversely, you just mentioned that, it doesn't have to be 4 weeks.
Yes.
Have you injected at 2 weeks and a lot of situations?
Absolutely. Yeah. The ones that are injected at 2 weeks are patients who are treated every 4 weeks and are wet, intraretinal fluid, and have poor visual acuity improvement or poor result. And what I'll do is I'll inject them at 2-week intervals. Now, in the US, most of our patients, well, most of our patients have insurance, either private insurance or Medicare, which is a government insurance. And both of those situations will only pay for branded drugs, Eylea, Lucentis, Vabysmo, every 4 weeks, longer, not less than 4 weeks. But what they will do is they'll pay for less than 2 weeks for bevacizumab because it costs us a small fraction. So I'll treat them with bevacizumab, and then I'll bring them to Eylea, and then bevacizumab, and then Eylea, and I'll go through 4 cycles, and I'll see if that works. I treated one. The most I've ever done is every 2-week therapy for 1 year. It was a patient who had pseudophakic cystoid macular edema. Now, of course, pseudophakic cystoid macular edema is not an indication for anti-VEGF, is it? Except the patient was a steroid responder and could not tolerate topical steroid anti-inflammatories, could not tolerate Dialox. And so I didn't know how to treat her. And anti-VEGF is, the anti-VEGF drugs are called inflammatory cytokine, or VEGF is an inflammatory cytokine. And so it causes inflammation, etc. And so there's probably a VEGF component to this. And so some patients will respond to anti-VEGF drugs, but it's never your first choice, ever, or your second, or your third. But when you backs up against the wall, you have nothing to do. And I treated this patient for a year and the CME went away. Now, did it work or did she get lucky? I don't know, but she did.
When did you start believing that it is a right line of treatment? You said it took almost a year.
As opposed to resolution. And we first described Q2-week therapy back in 2012, I think it was our first paper that did this. So it's a therapy you can use for selected patients. And those are Q4-week patients that you'd like to, and you've tried the other options.
Combining two.
Two injections of 2 different anti-VEGF drugs at the same time every 4 weeks.
Steroid combination.
Yes, so steroid combination, sure. So the steroid combination of inclusions and diabetic macular edema, absolutely. But I'm not convinced that, say, an Ozurdex or steroid works very well in macular degeneration. I've heard people argue with me, but I don't think it works very well for macular degeneration. So for those patients, I wouldn't do it. But for the other patients, yes. Now, having said that, there's steroids added on to, if you have an incomplete response to anti-VEGF every 4 weeks, and it's not very good, and you add a steroid to it, what happens? Does it get dry? Absolutely. Does the vision improve? No. And so there were 2 trials that did that. One was the DRCI-NET protocol U that looked at ranibizumab adding Ozurdex. The patient didn't respond. And that's exactly what they found was the steroid patients got really bad. The vision didn't change. And that was based on a trial that was published a couple of years earlier that I did with a guy named Raj Maturi out of Indianapolis. So we did the same thing with bevacizumab. Bevacizumab, incomplete response. Bevacizumab monotherapy, bevacizumab plus steroid. Worth a try. I think it's worth a try. I'm not convinced you see better visual acuity results. And what I think happens is drying is not always the endpoint in patients with, say, diabetes or vein occlusion, and that you get a pro-visual acuity effect by giving anti-VEGF that's independent of drying.
If I have to compare between combination versus 2 weekly treatment.
Yes.
That's what I.
With the combination therapy. If I'm going to do that, yeah. And usually my combination patients are macular degeneration. That's the usual ones. I do combination, Q2 weeks.
I
have
did you
question.
insist? Sorry.
Taking it to PCB, there
Yes.
are probably 3, 4 cases, you have been treating either with Eylea or Rolizumab, and suddenly get it after injection or just before injection. So can you predict what those patients could be or any?
Yeah, I don't know why. Obviously it's a active polyp. What's interesting is the people who have published the most on this are, the Pacific Rim group, especially people out of Singapore, and they're moving more and more away from photodynamic therapy as an adjunct to anti-VEGF. Because the Planet trial showed that anti-VEGF works pretty well. It doesn't regress the polyps as well as you might get with PDT, but it does well visually and fluid-wise, every bit as well as combination therapy. And now we have the second generation agents. Programs have shown very well to control the disease, not to close the polyps permanently, because we don't really think that ever happens, or we can't predict it. But as a monotherapy, it seems to work very well. Patients like that have benefited from ICG every 3 months and PDT, and the answer is I don't know. But I do know that they're moving much further away from PDT as a combination therapy.
With
Your experience with 8 milligram Eylea in 8.9 patients, or do you reserve the drug only for switching it from 2 milligram to 8 milligram?
Treatment naive.
Do you have any cases?
Yeah, let me see a couple here. Oops, help. There are more slides.
Till this comes on, another question was with 8 milligrams of aflibercept, did you see any increased incidence of intraocular inflammation or occlusive retinal vasculitis?
So, one case of inflammation. And it was a case where years prior, 2 milligrams and had intraocular inflammation. And then the patient, after a while, started responding poorly to bevacizumab, and I gave the patient a single injection of 8 milligrams. What happened was very interesting. The patient was 20/40 with considerable edema, and I gave her 1 injection of 8 milligrams, and she came back 5 days later with significant vitritis. Now, it was said to be 4+. Now, the retina specialists here know that 4+, you can't see the retina. But her vision was 20/40, so that didn't make sense. But 3 days later, the patient came back and saw me, and the vision was 20/30 with no macular edema. And that was a week after starting the inflammation. So it worked really well to dry up the macula despite the inflammation. So that's the only one I've had. Occlusive vasculitis, I've never had any. And we know that the incidence of occlusive vasculitis with aflibercept 2 milligrams is only a little less than 1 in a million. So, inflammation, you're very unlikely to get occlusive vasculitis, and so the inflammation you get will be reversible. For people who have inflammation after an anti-VEGF injection and it goes away, do you ever re-challenge with the same drug? Did anybody do that? No, I tend not to. I think there's an increased risk of developing a severe reaction. Some people do it. But I think there's an increased risk of developing a more serious reaction like an occlusive vasculitis. So I tend not to do it.
In the same way, I had a central retinal artery occlusion post brolucizumab. Then I had an infected end of post, after so many years of Ozurdex, I had a streptococcus end of after Ozurdex. Have you seen such cases, or you're aware of your colleagues in US facing such a thing?
Well, I've never seen
Ozurdex streptococcal endophthalmitis developing in about 10 hours.
10 hours?
10 hours.
Whoa, that's really unusual. So, can you get endophthalmitis? Sure. Obviously, we know that post-injection endophthalmitis strep is actually pretty common. It's much more common than general post-operative, and we think it's because people are talking in the room and their oral pharynx drugs, which are strep, going around and hitting the eye. 10 hours is really short. Usually it's 2 to 5 days, but strep is more common post-injection than it is in post-surgical. Yes. Here's the case I showed you previously, when the patient was put on faricimab, 3-month injections got worse. after aflibercept 2 milligrams. So now aflibercept 8 milligrams available. So here's first injection, second injection, third, fourth, and you can see not dry, but a considerable reversal of the edema and improvement in the vision back to 2040. I actually got the patient out to around 7 weeks, and she was pretty happy and stable like that. So really nice reversal of the swelling and the visual acuity loss in this patient. Here's an 82-year-old patient who had macular degeneration. Patient treated with aflibercept 2 milligrams for a couple of years, vision 2050 to 2060 with that fluid. And put the patient on 8 milligrams, and we get some degree of improvement in visual acuity, a few letters to bounce around, and we get almost complete drying of the macula, but not. So significant improvement, and the visual acuity a couple of letters better, and a couple of letters after a switch is probably all you're going to expect to see, but certainly an effect that I was not able to get with 2 milligrams. And let's see, here is this patient, new onset vascular age-related macular degeneration, fluid in all 3 compartments, patient treated. And this drug in the Pulsar trial, all patients with macular degeneration were treatment naive. They're all newly diagnosed. So you can see first injection, almost complete drying. I actually went 7 weeks after after the initial injection, and the patient continues to dry 9, 11, and then up to 15 weeks pretty quickly, and really nice drying effect in 2030. I don't believe in macular degeneration that 3 is a necessary loading dose. I don't believe that. I think you treat monthly until you get the disease under control, and once your disease is under control, you've done your loading doses. But that would be an injection. And so I don't believe 3 is necessary. And I think the CAT trial showed that very well. And if you ask Dan Martin, who ran the CAT trial, what's your loading regimen for macular degeneration? He says 1 of the loading dose. At least 1 until you get the disease under control. Here's another case. You can see what looks like fluid through here and hemorrhage through the top of the macular bundle, and some of the fluid through the macula. And so this patient's 2050, baseline 1 injection. And if you look at the maps here, it's really interesting because this fluid here is almost completely gone after the first injection. And then what you have is this spot up here. And what that correlates with, see the leash of blood vessels from the disc? And then a nest of blood vessels up there. So that's a little slower to resolve. And then by the time we get about our 4th injection, you can see there's no thickening up there whatsoever. The patient's out at 7 weeks and then going forward from there. So that's 8 milligrams in treatment naive. Here's a 73-year-old physician, 2060 baseline, 4 weeks after the first injection, 2040. So really nice drying effect. And this is pretty typical of 8 milligrams. If you look at the data out of Pulsar, and this is one of those secondary analyses, that it dries better, it dries faster than 2 milligrams. So if you'll put this maps, the graphs that we see in Pulsar, you see, this bouncing around. Well, it's bouncing because after 3 monthly injections, they went to 16 weeks. And I don't think any of us would really be happy doing that. It worked for the trial, but it's not how we would treat patients in real life. But after 3 injections, at every single 4-week interval through the first year, there were a greater number of patients with no central fluid in the 8 milligram cohort than there were in the 2 milligram cohort in Pulsar. That's despite the fact.
My question is with regard to the 2 milligram and 8 milligram. Since 8 milligram is likely to be available in India soon, and you've used it for many years. So in the transition when both were available, today, what percentage of patients for neovascular AMD and for macular edema do you use 8 milligram as compared to 2 milligram? And how has that changed from when you first started using it?
Yeah, so when I first started using, first came out, and so I'm at that point. About 2 mab, and about 40 were receiving aflibercept 2 milligrams. And now I fast forward to where we are today, and it's about a third on bevacizumab. Most of those were patients from years ago that just kept going. About a third on aflibercept 2 milligrams. I mean, they've done well. Some of those have switched to 8 milligrams, and the newer patients have gone to 8. So it's roughly a third bevacizumab, a third 2 milligrams, a third 8 milligrams. Some of my colleagues will say, well, there's no reason to give 2 milligrams because you have 8 milligrams. True, but if it's 2, why rock the boat? This is more expensive than 2. And so there's always that thought that comes into play as well. But it's about a third. And then I have a few patients that I treat with faricimab that I inherited from 2 of the other physicians that have since retired from the practice. And if they're doing well, I keep them on faricimab.
Same for DNE and is the percentage?
Yes, it's about the same for both, correct. I take it back. For DME, because anybody who's 20/50 or better, there are fewer patients on bevacizumab, more on the aflibercept 2 milligrams and 8 milligrams in the 20/50 or worse. So in general, in diabetes, I've got more patients on aflibercept compared to macular degeneration.
Before switching between biomarkers.
Is the intraretinal fluid and subretinal fluid important? Has the subretinal fluid gotten better or not? Is the pigment epithelial or detachment worsening? Is the intraretinal fluid, which often is one of the reasons for switching, is poor visual acuity and persistent intraretinal fluid. Epiretinal membranes, I'm starting to pay more attention to those. And in diabetes, I have a very low threshold for doing macular pucker surgery in a patient with diabetic macular edema. And I'm beginning to rethink my reluctance to do macular pucker surgery in macular degeneration patients, because just reviewed a big paper that looked at a meta-analysis in the literature, and one of the things that it found was the absence of a vitreous detachment meant that the patient required more injections. And so, so probably do a vitrectomy sooner in some patients. I don't want to do a vitrectomy in every macular degeneration patient, but please keep in mind, I'm probably doing macular pucker surgeries earlier in macular degeneration patients that aren't responding very different literature from the basic science literature that says traction on tissues, increases VEGF levels. So it may be that an epiretinal membrane, which is a form of traction, actually perpetuates and encourages the VEGF production within the tissue.
I think the VEGF, the sink, the vitreous sink.
Right?
Last night.
Two different questions. We talk about the diabetic side and we talk about the macular degeneration side. So on the diabetic side, it's an easier story, because we have 2 different trials that showed us really clearly that doing a vitrectomy did not disadvantage patients in terms of resolution of the diabetic macular edema. And that was the RCRNet protocol I, where they did post-hoc analysis, and Champlain with Ultradex. So if you do a vitrectomy in the diabetic eye, we can get to the same endpoint. We don't have that good data to give me the same clarity. Reluctant. But that's why I'm now starting to rethink that in the eyes that aren't doing well, because the basic science says that it may be these patients will do better, but they might need more frequent injections. So I'm still puzzling that one over.
Or do you think steroids post surgery? Like Ozoltex?
I'll start the end. I'll keep surgery, then I'll continue on to VEGF afterwards. If that doesn't work, I'll switch to steroids. So VEGF is still going to be my first line afterwards. If that doesn't work, I go to steroids. I don't mind cataracts. I hate glaucoma. And so I see if it dries really well. To use it because of glaucoma. I had one 55-year-old gentleman who never had any eye issues until he developed a branch. gave him Ozurdex, and he went right down to filtration surgery. Couldn't get his pressure down. So things like that really weigh on me.
So thank you, Dr. Stewart. I think we have some more agenda for the evening. So thank you so
Thank
much
you.
for such an engaging discussion.
Thank you.
For next, to the dais, Dr. Nishikant Borse,